Ladies and gentlemen, we now turn to the afternoon portion of our Digital Health Symposium, beginning with our Panel 3 segment titled Connecting the Dots, Establishing Broadband Connectivity as a Social Determinant of Health Domain. This segment will be moderated by the Senior Advisor for the FCC's Connect Health Task Force, Dr. Chris Gibbons. Dr. Gibbons?
Thank you, Ben, and welcome back. Hope you had a good lunch. We have another very distinguished panel to meet with you today, and the purpose and goal of this panel is really to learn more about the work that they are doing in this area and also to hear their perspectives on what else can be done to advance the role of broadband as a social determinant of health. And with that, why don't we get started? We will start first with Dr. Gopal Singh. We'll have each of the panelists introduce themselves and give their talk as we go forward. Dr. Singh?
Thank you, Dr. Gibbons. Good afternoon, everybody. My name is Gopal Singh, and I'm with the Health Resources and Services Administration, HRSA Office of Health Equity. Today I want, next slide, please. Today I wanted to briefly talk about broadband connectivity as an important social determinant of health and how access disparities are strongly related to health inequalities, both at the individual and the community level. Next slide, please. The findings that I describe are primarily based on the Census Bureau's American Community Survey and CDC's National Vital Statistics System. Next slide, please. Let's move to slide 5, and then we can come back to slide 4. Sorry. Okay. Thanks. According to the 2017 American Community Survey, about 17% of American adults aged 18 and older did not have a broadband internet subscription. Disparities in broadband access are fairly stark if you start looking at differences by education, income, race and ethnicity, and geographic area. For example, 27% of those with household incomes below the poverty level did not have broadband subscription, compared with 11% of Americans with incomes at or above 5% of the poverty threshold. And you can also see that about 90% of Asian and Pacific Islanders and 84% of non-Hispanic whites had broadband service, compared with only 66% of American Indians and Alaska Natives, 77% of African Americans, and 79% of Hispanics. Let's go back to the previous slide, slide 4, please. As you can see here in this map shows huge disparities in internet access across 33,000 zip codes in the United States. This is based on the 2013 to 2017 data, but the pattern should be very similar even with the more recent ACS data from the Census Bureau. And as you can see here, that zip codes in dark red have broadband access of less than 62%. And as you can see that these are mostly concentrated in the Southeast, Southwest, and Appalachia. Next slide, please, slide 6. Thanks. The rural-urban divide in broadband access is quite marked. More than 30% of the rural population lacks access to broadband internet, whereas you have 20% of the urban population that lacks broadband internet access. You can also see that the ones I think in, let's see here, the small rural towns, there you have over 35% of the people lacking broadband access. Let's go to next slide, please, slide 7. As you can see here and in the next 2 slides, disparities in broadband access are strongly linked to health and social inequalities. For example, if you look at life expectancy, compared with communities with low internet access, that is quintile 1, have 7 years shorter life expectancy than communities with high access, that is quintile 5. So you got life expectancy of 75 years versus 82 years. Communities with low internet access are also at increased risk of mortality from various chronic conditions such as cardiovascular disease, cancer, diabetes, poor health, disability, mental health, mental distress, preventable hospitalization, smoking, obesity, physical inactivity, reduced access to healthcare, lower educational attainment, and higher unemployment and poverty rates. To summarize all of this then, we can skip all of the slides. I think I already sort of covered all of those. To summarize then, broadband access is an important predictor of population health and healthcare outcomes, often independent of other social determinants such as education, income, employment, and race and ethnicity. So closing the social divide in broadband internet access can positively impact individual empowerment, educational attainment, economic growth and opportunity, community development, access to healthcare, and health-related information, and health equity efforts. Thank you. I will stop here. Dr. Gibbons.
Thank you very much, Dr. Singh. Next, we'll go to Dr. Jill Egith from the MITRE Corporation. Dr. Egith.
Perfect. Thank you. Can people hear me?
Yes.
Okay. So first of all, I want to say it is wonderful to be here today, and my neck is exhausted because I think that all I've done for the past 3 hours is nod vigorously in agreement and in support of what everyone else has been saying. And I'm also worried at this point, there might not be anything new for me to say because I feel like there's been so much great content so far. So a little bit about myself. I'm a health psychologist by training, and I'm also the managing director of MITRE's Healthcare Delivery and New Opportunities Division in the Health FFREC. And I'm part of a team that over the past year has been working to develop a national strategy for digital health. We published our first version of the strategy back in May of 2021, so nearly a year ago, and we published it intentionally as a draft document with a draft watermark. We spent a year chatting with people about it, gathering feedback, making revisions, and we have a new version of that national strategy that's actually just being released today. And while I was sitting here just now, I got a note that the new strategy is live on the MITRE site. And so once I'm finished with speaking, I'll link everyone to that new version of the strategy. What I'm going to be talking about today is a portion of the national strategy, which is linked to broadband access. So next slide, please. So our strategy is not just focused on broadband access, it's focused on digital health. And we're really talking about the digital health ecosystem, which I think has now come up multiple times throughout the day, the way that all of the different parts need to work together. And the way they don't always work together. We have pieces that are not necessarily integrated with intentionality and planning. And we really we put together this strategy because we wanted to focus on the ecosystem, how all of these different parts need to work together in order to function and in order to achieve the health outcomes that we're looking for. And I should also say up front that I'm not the author of the strategy. I led the team of people who are subject matter experts in various areas. So probably at least 30 people helped to pull this together. So this is really reflective of some of the best thinking that MITRE has to offer in this space. So when we're talking about digital health, we're talking about the convergence of health-related sciences and digital technologies that really, under the best circumstances, empower people and populations to manage their health and their well-being. And it includes things like mobile health, telehealth, health IT, wearable devices, and personalized medicine. Next slide. We put together a national strategy because, as has been mentioned innumerable times today, COVID-19 really served as a watershed moment for us. And it really just highlighted issues that were already there. It brought them to our attention. And we decided that we needed to put together a framework that would help the nation to identify priorities and lay the groundwork for change so that we could move forward in a very intentional and planned way. And this national strategy is written for leaders in the digital health community, people in government, care providers, community champions, academe, tech developers, for everyone who plays a key role in this digital health ecosystem. Next slide. One more. All right. I am not going to be talking about everything on this slide, so do not worry. Let me just quickly share the major goals and objective of the national strategy, and then I'm going to focus on the one that's highlighted in yellow here. So the national strategy, the vision of it is improved health and well-being of the nation, powered by a digital health ecosystem that's functioning well. The goals are to form a connected health ecosystem defined by timely, secure data exchange, empower individuals to take charge of their health and well-being, establish artificial intelligence as a trusted cornerstone of digital health, institutionalize rapid sharing of integrated data for public health, build a workforce skilled in application of digital health, and grow digital equity to achieve health equity. And that's where we're going to be focusing today. Next slide. So underneath of that broad goal to grow digital equity to achieve health equity, we have three main objectives. I'm going to be talking a little bit about two of them today. So the first objective is to create a new national broadband plan. We want to ensure community engagement in digital health development and research, and improve our measurement, monitoring, research, and practice to account for inequities and for varying levels of access. We really need to be able to measure in order to understand today's baseline status so that we can properly adjust for future improvements. Next slide. All right, let's talk a little bit about this objective that's focused on creating a new national broadband plan. We need a new plan that can help us consider the expanding needs and the widening digital health disparities among US communities. As people have noted, there's great promise in digital health. And for many people during COVID-19, things worked really well. But we can't just continue with today's status quo because we run the very real and serious risk of widening current health disparities if we don't start paying attention to access to virtual care for all. We want to provide opportunities for all communities to participate in broadband needs assessments and proposed interventions, create accurate mappings of broadband availability and speed, include broadband capability as part of a larger plan to develop smart communities, and create a government-wide approach to broadband adoption and affordability that replaces the current approach, which is quite fragmented. Next slide. We also want to improve measurement, monitoring, research, and practices. If we want to track our progress towards health equity, we need to have continuous capture of indicators so that we can monitor access to digital technology, use of that technology, and the skills of diverse populations. We want to enhance measurement of successes and failures in digital access and equity, create and apply a systematic approach for assessing equity impacts of digital health interventions, design the right kinds of metrics so that we can enhance measures of digital health, ensure that analysis includes a focus on different populations that have faced unique historical barriers, and create appropriately tailored solutions, and take steps to minimize bias in AI and the underlying algorithms. Next. And let me just quickly address the need for governance reform. This we sort of saw as an objective that underpins the whole digital health ecosystem and forms one of the baseline requirements for our framework, our proposed national strategy. There is no overarching body to govern the digital health ecosystem, which means that it's very easy for different elements and components of the ecosystem to kind of go off and do their own thing. And we think that a governance reform is needed to help bring some cohesiveness. The first thing that we recommend under governance reform is declare digital health a national priority. And that could be one of the first steps that we take towards getting broadband access accepted as a social determinant of health. I'm going to stop talking here and save some of my other comments for the panel.
Thank you very much,
Yeah.
Dr. Iga. Next, we'll hear from Susan Denser. Susan?
Thank you very much, Dr. Gibbons. I'm Susan Denser. I'm the incoming president and chief executive officer of America's Physician Groups. We represent more than 335 physician groups across the country, focused on provision of coordinated, patient-centered care, integrated care, and accountable for cost and quality. In previous roles, among other things, I was the editor-in-chief of Health Affairs Journal, and also I led a project funded by the Gordon and Betty Moore Foundation several years ago to create this report, Healthcare Without Walls, which really saw the potential that has been discussed many times today, including by Dr. Berwick, to really push care outside of conventional healthcare institutional settings to individuals in their homes and communities. And I just want to brag on our effort by saying, we said back in 2018 that we should start planning for a pandemic and how we would use and adopt rapidly digital health strategies in a pandemic. So it's nice to see that we now consider COVID-19 a watershed in the take-up of all of these strategies. As was said, at this point in any kind of a forum, most of the important things have already been said. However, not everyone has said them yet. So I'll just take a couple of minutes to recap what I thought I heard this morning that I think and earlier this afternoon that really provides a basis for the second set of my comments, which is where do we go from here in this discussion about social determinants of health and broadband access as one of those social determinants of health. So what did we hear today? First of all, we heard unequivocally that access to broadband internet is a social determinant of health in itself, and it's also embedded in the other social determinants of health. It is itself a highway to health. That's a wonderful phrase that Don Berwick used. We heard earlier from Karen Onije about the FCC study showing clearly that counties with greater broadband access had lower diabetes prevalence, even after you controlled for various other factors, other aspects of the social determinants of health, education and income, for example. And as she said, not only is it clear how often and starkly broadband correlates to these outcomes, all of these others are also linked to broadband access. So we heard that loud and clear. And Gopal Singh's slides, I might add, drove that point home. Think about the map showing nationwide broadband access and the areas of the country that have very low broadband access, how much those completely correlate almost on a one-to-one basis to a map of cardiovascular disease prevalence, stroke, obesity, et cetera. All right, so that is a key takeaway. We also heard that broadband access is a critical platform in reinventing the way we provide care. Now, we heard a lot today about telehealth and remote patient monitoring. I just want to add to the list, how about hospital at home? As a consequence of the pandemic, hospital at home, which is a more than 30-year-old strategy, has now been taken up by more than 200 health systems now operating under CMS's acute hospital care at home program. Think about what Joe Dragas said a few moments ago about his mother battling cancer, and couldn't a lot of that battle be undertaken at home? We already know the answer to that from some of the extant cancer hospital at home programs. The answer is yes. So how do we get more of that home-based access to hospital care in the home nationwide? The only way we will do that is with much broader and more reliable broadband connectivity. That is a key feature of any effective hospital at home program. So we also heard from Don, as he called out Dr. Marmot's wonderful various social determinants of health. I will say Dr. Marmot went through several iterations of this himself. I go back to the one he used in this book in 2006, where he talked not just about 5 social determinants, but 6 priority areas, the quality of experiences in the early years of life, number one, education and building personal and community resilience, number two, good quality employment and working conditions, number three, having sufficient income to lead a healthy life, number four, healthy environments, number five, and six, priority public health conditions, taking a social determinants approach to tackling smoking, alcohol, and obesity. And once again, if we think about those six domains, we can think about how broadband access infuses all of them. How we can use a Project ECHO type approach, not just, as Don Berwick said, to get education out to nursing homes. Think about what we could do to extend, for example, diabetes support and obesity reduction programs increasingly into communities via broadband access. So we see this embedded throughout in all of the social determinants of health, no matter how we categorize them and how we measure them. All right, so having heard all of this, now what? What do we do if we agree, for example, that HHS and all of its agencies should emphasize broadband as a social determinant of health, either as a standalone SDOH or integrated and embedded into all the other social determinants of health? What is our theory of change? How would this matter if this were to take place? And this, I think, is very, very important to ask in the US context. Think about a place like the UK, where, first of all, you have a national health service that can adopt initiatives and pretty much with difficulty effectuate them throughout the system. Or even in the UK, where a minister of loneliness was created a few years ago out of the clear recognition that loneliness and social isolation is a social determinant of health. We don't operate that way here. We would not create in this country a new department of broadband and a cabinet secretary of broadband. We don't have a national health service. We have a federalist system with responsibilities split up between the federal government and the states, and a constant tug of war between those two on matters relative to health. Need I point out what has occurred during the pandemic? So if we ask, what is our theory of change in the US context? Basically, we're saying, what would happen if HHS did consider this a social determinant of health? When you think about theories of change, you think about inputs, you think about activities, you think about outputs and outcomes. So what would be part and parcel of this theory of change that would flow from declaring broadband access a social internet of health? What additional inputs would we need into that process? Probably more studies like the ones we've heard about today, more understanding of the correlation and causation between broadband access and health outcomes across multiple priority health conditions. Activities, next step. What would HHS agencies do differently? Would we have more interagency collaboration around this? Would, hearkening back to Dr. Ega's presentation, would declaring digital health a national priority unify those agencies around a common mission? Karen Ruben talked about the need for more strategic planning across federal agencies around telehealth, more partnership with the states, particularly to address some of the licensure and other issues that we know have been overcome in the pandemic, but probably are going to be reinstituted as problems post-pandemic. So what would those particular activities be is really critical. Outputs, what would occur? What key results are desirable from both a policy and an operational perspective? That area requires a lot of thinking. And then finally, outcomes. What outcomes would we expect at the end of this process? Would there be greater efforts to target priority broadband internet installations, say, in counties with the highest area deprivation indexes? would that be an outcome that we would seek to achieve? Would we ask for a health in all policies approach to implementation of the broadband expansion underway that we hope will be underway under the Infrastructure Investment and Jobs Act? Would we, basically hearkening back to what we heard from Elizabeth Myers of ONC, would we essentially be targeting more cloud-based solutions and data solutions to create this nationwide mesh that she described to move data across the country? And then beyond infrastructure, to pick up on a point that David Ahern made, let's just not think about infrastructure. Let's think about these other outcomes we would want to achieve around access, around adoption, and use, particularly use. To what end would we want the Food and Drug Administration to be more actively involved in user-centered design issues with respect to digital technologies so that we can make sure that they can be used and taken up by very diverse populations? So as I step back from all of this, I think there is a lot of work left to be done to flesh out this theory of change. But to my mind, it would be a crucial next step. And I look forward to engaging with our other members of our panel on discussing how we get to devising that theory of change. And of course, in the end, taking it up, which would be the most important objective of all. So thank you very much.
Thank you, Ms. Stedner. Next, we will hear from Dr. Gretchen Purcell Jackson. Dr. Jackson.
Thank you so much. Well, Susan, you say there's a lot of work left to be done, but those, I think, were some really fantastic, pragmatic recommendations to inform this dialogue that we're having today. So I'm really grateful for the opportunity to contribute to this conversation as a surgeon, a scientist, a healthcare technology executive, and a health informatics leader. I'm a scientific medical officer at Intuitive Surgical, which is a surgical robotics company, and I still practice pediatric surgery part-time at Vanderbilt University Medical Center, where I'm a consumer health informatics researcher. I am also the board chair and president of the American Medical Informatics Association, or AMIA, which is the leading scientific health informatics organization in the United States. AMIA is a professional home to over 5,000 informatics professionals, including clinicians, scientists, educators, trainees, public health experts, and industry professionals. And AMIA and its members have endorsed access to dependable and affordable broadband as a social determinant of health for many years. So I think the things that I will say today will echo what you have heard earlier today. Our field, like others, recognizes that populations without access may be unable to participate in or benefit from the emerging care models involving telemedicine and health. And as Susan acknowledged, this notion of home monitoring or care at home, and this lack of access, of course, may exacerbate the already significant health disparities. Now, AMIA has provided letters of support and offered input to a variety of the FCC strategies and projects, including initiatives to promote telehealth for low-income consumers and to inform the FCC's approach to accelerating adoption and accessibility of broadband-enabled healthcare solutions. And in these communications, as well as in the scientific and advocacy work that our AMIA community has done, several themes emerge. And again, I think I'm repeating some of the things that have been said before, but several themes emerge that I'd like to share that are relevant to this conversation. First, access to wide bandwidth data transmission alone isn't enough. This access must be affordable, reliable, and safe. And disparities in any aspects of that access should be treated as a public health issue. Second, embracing and addressing access to broadband as a social determinant of health will likely require us to capture and leverage accurate information about this characteristic. And like so many of the social determinants of health, this information is not consistently captured or shared across our health information systems. So to do so, we will likely need standards for representation, as well as just a commitment to gather this information as part of the healthcare experience in the variety of ways in which that experience takes place. Now, third, access to broadband is not just a rural health issue. Many underserved populations in urban settings only have access to broadband through public or shared devices. And this exposes these already vulnerable populations to increased privacy and security risks, as well as other opportunities for exploitation. Fourth, as technologies mature and evolve, safe and reliable access to broadband-enabled healthcare solutions will likely require new skills and knowledge for patients, caregivers, and their providers. And this education to address creating these new knowledge and skills will be an important part of what we do going forward. And finally, optimal solutions to these barriers to addressing broadband as a social determinant of health will likely require creative and collaborative engagement of all of the stakeholders in the healthcare ecosystem, including providers, payers, corporations, federal, state, and local governments, as well as the patients, caregivers, themselves, and the organizations in the communities in which they live. So I'm grateful for the opportunity to take part in this conversation today and look forward to the discussion.
Thank you very much, Dr. Jackson. And finally, but not least at all, we have Lauren Replinger. Lauren?
Thank you. And thank you for the opportunity to join this important conversation today. I'm the Vice President of Policy and Government Affairs for the American Health Information Management Association. And just to provide a little bit of information about our members, our folks work with health data for over 1 billion patients a year. And many of our members work at this intersection of healthcare technology and business, and can really be found in data integrity and information and privacy job functions around the world. And so I love the way that Susan has framed this theory of change conversation today, because the lens that AHIMA specifically brings to this conversation is really thinking about what are the steps that need to be taken beyond having broadband identified as a social determinants of health domain to really achieve this end goal of improving health outcomes and equity. So really thinking about this last mile. So for example, Gretchen mentioned about the need for standards, right? And so what are the technical standards as well as the terminologies and code sets that we really need to make sure that we're accurately capturing this information? And tied to that is, do we have consensus across healthcare organizations as well as social service organizations that might collect this information as to what broadband as a social determinant of health means? Because when we get to, when the rubber meets the road and we're exchanging this data, we want to make sure that we're being consistent about on both sides as to what that actually means. But even taking a step deeper, we also think about, again, these operational considerations around accessing this information. Who's going to be responsible for collecting this information? Is it the provider? Is it the case manager? Is it someone else within the hospital? What are the barriers that we see today and in the future around the collection of this information? We know administrative burden is a huge challenge for providers. So how do we encourage them to document this additional information? We also know, even from a coding perspective, our medical coders, there are coding productivity standards in place that oftentimes discourage them to make sure that that information is within and contained in the record. Some of my colleagues on this panel also mentioned some of the privacy considerations when we're sharing this information across organizations. I think it's critically important we think about, what does the data governance framework look like for that? And I know the last panel talked about this as well. What are the feedback loops in place to make sure that, if a provider documents that connectivity is a challenge for a particular patient and shares that with a social service organization, that if that is addressed, that provider knows that so they can focus on other things for that patient. But I also think we need to look at it from a patient perspective. We want to make sure that we're encouraging patients to share their social challenges and make sure that providers are being transparent and communicating clearly the purposes for which that information is collected and used. We know today that there are challenges and patients often don't feel comfortable about sharing that personal information. So how do we encourage them to do so and make that connection between the documentation of that particular data and the eventual outcomes for that patient? But of course, also tied to that is we want to make sure that we're protecting against the stigmatization, discrimination, and implicit bias in the use of this information. You know, Jill also mentioned a little bit about workforce education needs. I think we have to acknowledge at the end of the day that we may have to undertake some workforce training in order to make sure that folks in the healthcare community are prepared to collect this information and to do so with cultural humility and sensitivity. So I think, you know, these are some of the issues that AHIMA thinks about and are working on, and we can't forget about them because at the end of the day, we want to make sure that we are making the right interventions and helping to track outcomes and ultimately making good policy at the end of the day. So thank you for allowing me to be a part of this conversation.
Thank you very much. And thank you to all the panelists for your initial comments here. They're all very, very significant, and we'll try to dive in on some of these ideas and then give the panel or give the audience an opportunity to engage. There were some things that were said that may not be understood by everybody. So I wanted to start by just getting out some definitions. And maybe we'll start with Susan. Susan, you talked about the hospital at home model. And for those who don't know, it actually is a specific thing. It just doesn't mean taking care of somebody or being cared for at home. Could you talk just a little bit more about what that is to help everybody understand?
Sure, absolutely. So hospital at home is a model that actually was created initially internationally in other countries. The US version of it is pretty much credited to Dr. Bruce Leff at Johns Hopkins in the 1990s, who essentially discerned that there's a large number of patients who are routinely hospitalized for generally mild, relatively mild, less acute, still acute, but less acute medical conditions. You can think about pneumonias, for example, exacerbations of heart failure, that a lot of those patients ended up in the hospital when with the right services and supports, you could actually take the equivalent of the hospital home to them in their homes with the right schedule of visits from providers, with the right additional equipment, et cetera. And when this approach was tested in a number of places, including at Hopkins, it pretty consistently showed superior outcomes to hospital stay for most patients, consistently lower costs, about 20% lower costs, off the chart patient satisfaction, et cetera. And despite these very compelling results, there was almost no take-up of this model to speak of across the entirety of the US healthcare system, except in very specific places until the pandemic. And as we know, CMS in the early days of the pandemic first recognized that there would need to be care provided outside of hospitals. So it adopted an initial approach of the hospital without walls, allowing hospitals to push patients with COVID and without COVID to hotels, to dormitories, to ambulatory surgery centers, et cetera. So that was phase one. And then in November of 2021, CMS came out with the acute hospital at home program. In about a 7-day timeframe, CMS did look at the evidence that had accumulated over about 20 years and said, we have to do this. And now, as I say, more than 200 health systems across the country are providing hospital at home under this CMS model. Of course, what was most significant is that this provided for payment, standard Medicare hospital payment for eligible patients who are able to be hospitalized at home. to have these kinds of systems work very effectively and truly have the hospital level experience at home, you need broadband internet access. You need 24/7 connectivity to a command center, to a hospitalist who might be in the institutional setting, connected, say, to a nurse. Karen Ruban talked about community paramedicine that UVA is using. That's another skill set that can be taken into the home, but those community paramedics need to be able to instantly access people in the hospital and say, here's what we've got going on in the home. What should we do? Should the patient be escalated back to the hospital, et cetera, et cetera. So you think about this in an era when it costs close to $1 million a bed to build a new hospital in urban settings of this country. Are we going to try to build more hospital capacity? Or are we going to try to free up existing capacity in individuals' homes for those people who could be cared for at home? Of course, that is the way we should go, but we need broadband as a key element of that platform.
Thank you, Susan. That was amazing. Just to reiterate, to help the audience understand just how profound of a shift this is. I remember when my home institution is Johns Hopkins. That's where I was on the faculty there for many years. And when I first heard about this model years ago, Hopkins was involved in those early studies. I worked with Bruce Leff. And you can imagine this, people would come into the emergency room, and under normal circumstances, they should be admitted to the hospital. So physicians would say, no, this person needs to be admitted to the hospital, but they would send them home. They were randomizing. Some would go to the hospital, some would go home. These are patients that every doctor was trained to admit to the hospital. We'd send them home, but then we'd do whatever we needed to do to get whatever care they needed at home. And as you said, it often involved broadband-enabled services. It could involve drones. It could involve any number of things. And as you said, the studies showed at multiple institutions, not just ours, that the care was about the same or better. The costs were lower. Patient satisfaction was higher than providing the same care inside a hospital. So this is the first time in the history of our nation that we thought about care. Fundamentally, the hospital was the place that it happened. But now that's fundamentally changing. And now we even have technology companies who are going after this in a very big way. They've introduced primary virtual first models where there is no hospital conceived of as being important to delivering care. So this represents a very fundamental shift in the way the healthcare system is thinking about delivering care. It extends to robotics as well. The technology needs to come up a little bit more before we can fully embrace that. But this is significant. Thank you very much. Similarly, let me just go to Dr. Eguth. Dr. Eguth, you talked about the ecosystem, and that's not a term that many people really understand. Could you just discuss for a moment what you mean by the ecosystem? Is it just another term for health systems, or is it something really different?
Yes, I mean, it's just think of all the many different components that comprise health, and that includes health care, it includes health-related data, it includes the public health infrastructure, it includes the humans, the workforce that we mentioned. It's data interoperability, access to data, it's health literacy, it's digital literacy, it's all of the different elements that when everything is working well, then our health system is working well. And not just when they're working well, but working together. So, as you think about any kind of ecosystem, if you think about what's outside your window, all of the different elements that need to be, working together in order to reach the kind of outcomes that we're hoping for. That's the kind of ecosystem that we're talking about. And it is huge, right? I mean, it is enormous. And that's one of the reasons we put together the strategy, because there are just so many different elements. And no one is an expert in all of them. Which is why I, caveated some of my comments by saying I'm not the one who wrote the strategy. One person couldn't write the strategy because the ecosystem is so vast that to have expertise in all of these different elements would just not be possible. Yet all of these elements need to be functioning well and working together in order to reach the kinds of health outcomes that we're hoping for in this country. Does that answer your question?
Yeah, no, that's fantastic. I mean, you're exactly right. I think the key word for me that I hear from you is two things, really. You're not just talking, again, alluding to what we were just talking about. You're not just talking about systems within a hospital working together or within a clinic. You're talking about social services. You're talking about clinical services. You're talking about caregiving services. But then you also said they all work together.
Right.
That's the key that defines an ecosystem, that you have multiple disparate parts that are able to work together. But the question has always been, how do you make that happen, especially when they're not all in the same building? And, how can they happen all at the same time? And the answer comes down to one thing: broadband. That's the only way you can do it. Right.
And I think the pandemic really illustrated how that broadband was really important for other aspects of health beyond that just formal healthcare delivery. For example, people needed broadband to have access to food ordering services or grocery delivery services. And in places that were shut down, this might have been the only way that people could get food.
That's exactly right. That's exactly right. We've sort of known this as a healthcare system, right? And it's certainly as a public health system. Public health people have known this, but even the medical care system has known health is about more than just medical services. We've said it, we were taught it, but we didn't live it as a system because it was largely about what we do in hospitals, and that's terribly important. So it's not to downplay that in any way, but you're right, Dr. Jackson. The pandemic blew that wide open. It blew it wide open and showed the whole. And so that takes me to the first question. I'll make it for all of you. But so you heard from a number of places, and even in the very first talk that Dr. Mancuso gave, broadband is this unique kind of thing, right? It really seems to work on multiple levels. Right? One level is connecting people with things. Okay, fine. But there's also some other effects that it has. And then finally, this gatekeeping function. Can't get to transportation, can't get to food, not only health services. As we go forward with this, and there's greater recognition of this and more embracing of this, what are your thoughts on how we keep the gatekeeping function that broadband does have from becoming a problem, and limiting, if people can't get those other things or their health care, it actually decreases health? What are any thoughts on that? We'll start with Dr. Singh.
I don't think I could address that. Something I would defer it to my colleagues here on the panel.
Yeah, and this is not to put anybody on the spot. These are just sort of questions. Yeah. Anybody at all want to hazard a comment on that?
I'll try my hand at that, but what I'm going to actually share is not necessarily a data-driven response as it is experience. Yeah. So I am the parent of a child who was in third grade last year when third grade was my basement. And all of the kids in my school district were sent home with laptops for the very first time, right? And it was because it was an acknowledgement of, not everyone has a computer at home. And I'm thinking, well, great, we did have a computer for my son. Now we have this laptop from school. What about all those other people out there who, now that they have this laptop, it's shelfware, they can't use it because they don't have broadband access? What about all of the parents who don't know how to use the laptop or to use the online school technology? It was a lot, at one time. And, the reason I'm mentioning this is because that's education, which is another huge, issue that is frequently considered separately. But perhaps for the purposes of this kind of conversation, as we're talking about how to advance the nation, it's not just health. It's not just education. It's not just how to order food during the pandemic. It's all of those things. I'm going to become known as the ecosystem person, I think. But it's like all of these things together. And maybe one of the ways that we need to start talking about access to broadband is not just in relationship to health, but think about the entire universe of things that are now tied to broadband access and how it is the gateway. I think that's the term you use, not just for health. And if we can bring together all of the different communities, the education community, should they be part of this kind of conversation, so that we can think together about how we can link arms and make progress together.
Fantastic. Anybody else? Yeah, sure.
Jill,
go ahead.
I probably would join you as one of the ecosystem people thinking very broadly. I would also say that we're at a time when technology is evolving very rapidly. So when you speak about that gating function, I think we have to worry about the bar continuing to move. You know, that computer that gets sent home with the kids. All the kids now have a computer, but that's out of date in 2 years. And as Jill said, do they have the knowledge and the skills and the confidence to be able to keep their operating system up to date or their security programs up to date so that they're not vulnerable to attacks? So I think that one of the things we will have to consider is as this technology evolves, do we have to keep up with what reliable, what dependable, what adequate, and of course, private and safe broadband looks like.
Very good comment. Absolutely agree with you. You know, it makes me think about the FCC's role, a potential role, and this is again for anybody, but I'll start with you, Dr. Jackson, since you just brought it up in this idea of keeping up. You know, even broadband, the definition of minimum broadband changes. You know, now at one point it was 10.1 up and down, 25.3. Some are talking about going to 100, or even gigabit higher than that. Do you have any thoughts and suggestions? Should the FCC or whoever say embrace this at a constant speed or tier and keep it that way, or should they build in mechanisms to update and as things go higher over time? Any thoughts on that?
Well, I think, we are looking at the bigger picture. As Susan and Warren and others have said, we really want to look at what does the impact of this access mean for disparities in healthcare. So if it is, you must offer 25 megabits per second download and, 3 for uploads, terrific. But does that allow you to do what is state-of-the-art healthcare? Or state-of-the-art health support, health enablement, as we look at engaged patients going forward, patients and their caregivers. So I think it really means that. And as you pointed out, what you need to do a video chat or, perhaps look at a short video for an educational purpose might be very different from the types of things that you need to capture video and telepresence for robotic surgery. And so I think what we need to do in looking at what is adequate or what is enough will be dependent on what capacities and tools are available.
Very good. Thank you. Anybody else want to add to that? It's a tough question. How much broadband is enough? But just any thoughts that any of the others of you have on that?
Well, sorry.
Go ahead, Susan.
Well, I was just going to say, just speaking to the notion of setting a given standard and then keeping it advancing, right, as the technology improves.
Right.
I'm not a historian of how the country adopted rural electrification or universal telephone service, but there probably are some lessons there, right? What was the baseline people started with initially, and how did that get updated over time? So I would say, let's go back and look at history and see how that was dealt with, number one. Number two, let's not let the perfect be the enemy of the good here, right? Let's focus, let's get as much broadband access at whatever level we decide today is a universal minimum requirement. Let's get that installed and build from there, because technology is always going to be advancing, right? That just goes without saying, but let's at least get a baseline in. I'm told that even Botswana has a plan to get to universal broadband access, right? We don't actually have that still, despite all, nobody has stood up and said, we will have universal broadband access for every American, right? So we at least have to start with that baseline and then work from there. But I think even setting that out as a bold vision, back in the early 2000s, George W. Bush said we were going to have nationwide electronic health records by 2014. It didn't happen, but he said it, right? We need the same kind of presidential level statement about universal access to broadband at the level that we consider adequate today, and then we'll build from there.
Fantastic. Anybody else want to add to that before we move on? I think you were trying, yeah, go ahead.
Yes, thank you. I'll add just very briefly, I'm going to put my data accuracy hat on here. And I think part of this conversation is also important to think about, do we need to think about subdomains within the broadband access itself, so that when we're really capturing this information, it's at the level of granularity that we really need to make those policy decisions. So I'll give an example. We're members or participate in what's called the Gravity Project, right? And this is a consensus building community to expand the availability of social determinants of health data for interoperability. One of the conversations they've been having since the beginning of this year is the topic of health literacy. But what they've come to the conclusion is that health literacy can also means personal health literacy. It might mean organizational health literacy. And even within those contexts, there's even subdomains, right? So thinking about digital health literacy and digital access. And so I think part of this conversation is also thinking about what do we really mean when we're talking about access, and are there other pieces that we need to break apart from this, so again, that we're capturing that information correctly.
Well, these are great comments. I want to just keep following with some thoughts, but we got to open it up for the audience. Samruti, are there some questions from the audience that we'd like to field to our panelists right now?
Absolutely. Thanks, everybody. And yes, we do have audience engagement, very robust. So 2 questions, at least I want to quickly pose. One is from Maria Pez Carlos. She's asking a question about any thoughts on the implementation of sustainability or quality improvements on broadband access. So that's one question. And I think I'll go ahead and share the other question. Are clinicians embracing the transformation of the healthcare model that include telehealth, digital health innovation, while understanding the social determinants of health? If not, how do we get them to embrace things change? And that question comes to us from Mr. Adam Gibbs. Thank you.
The first one more time, Samruti, that's sustainability. Could you just repeat that one more time?
Sure, happy to. So any thoughts on the implementation of sustainability or quality improvements on broadband access? And I want to invite the panelists, if one of you can address that quickly, and then we can turn to the next question. Thank you.
Panelists, anybody want to take a shot at that one? Well,
I think as Jill has suggested, sustainable solutions will be one that engage all parts of the ecosystem. And again,
have we lost Dr. Jackson? I think she's gone now. Anybody want to add to that?
I guess I would just go back to let's get it in place first. I think we have to rely on some of the things that we have going on for us in this country that are still positive forces. We've got competition in the private sector. We've got consumer demand and consumer expectations rising. I think we've got some forces in play that can improve broadband access over time. The ones we have to worry about, obviously, are the places where the private sector has been less inclined to invest. That's why what the FCC has done around launch and other pilots has been so important, which is creating more of the business case now for these kinds of investments. But so making sure that the whole of the ecosystem is engaged, as Dr. Jackson said, but that we're harnessing these forces of public dollars, public investment, and private investment to push this forward. I think maybe I'm naive, but I think good things will happen.
Great. Since we're running out of time, what about the second question? I think the second question was, do the panelists think that the provider communities are really embracing this? And if not, the notion of change with a social determinants of health lens? And if not, what can we do? Any thoughts on that? Anybody?
I'm happy to chime in. I think they are. I do think that there's a challenge we have to contend with, and that is right now there's a lot of social determinants of health that are being talked about out there. And so there's this question coming from the provider community of, I have a finite amount of time with my patient. What are the questions I need to ask about, and what do I prioritize, and what do I document in the record itself? And so I think if we want to have this data increasingly collected, we need to make sure that we have the incentives in place so that providers are inclined to capture that information. And I think tied to that is also making sure we are continuing to present the evidence that shows that linkage between broadband connectivity and improved outcomes and improved health equity.
Yeah, no, that was great. Lauren, you were the one that brought up the need for, defining broadband as a social determinant. I was going to ask you about that, but we ran out of time. So I appreciate that answer. I think it's a great answer. Anybody else want to add to that? Any other thoughts? Sam Rudy, do we have time for another question from the audience or no?
Thanks, Chris, but I think I'm afraid we don't have additional time, and I want to invite Ben to announce the next panel. Ben?
Great. Thank you very much, Dr. Gibbons, for moderating, and for our outstanding and impressive panelists for sharing your perspectives and for participating in the great discussion. Thank you so much.